Okay, everyone, we might make a start. So welcome to Monday Lunch Live. I'm Professor Grant McArthur, the Executive Director of the Victorian Comprehensive Cancer Centre. And to kick things off today, I would very much like to acknowledge the traditional owners of the land in which we meet, the Wurundjeri people of the Kulin Nations, and pay my respect to their elders past and present. I think most of you know the VCCC. It's a powerful alliance for the control and cure of cancer. And today we've got a very special Monday Lunch Live. So it's special primarily because of the content and the speakers. I'll introduce them shortly, Professor Julian Savulescu and Professor Dominic Wilkinson. But it's also special because we're in a very small room, and I have to give my apologies to some people who are unable to be within this room today. And we do have a breakout room upstairs in the building, and a very, very warm welcome to those that are joining us online today, where we've had one of our record number of online registrations, which is not surprising given the fantastic content today. So I'd now like to introduce our speakers, and first speaker will be Professor Julian Savulescu, who is the Uhiro Chair in Practical Ethics at the University of Oxford, and Julian's been there since 2002. Julian is a clinician trained in medicine, and I have to disclose that Julian was my intern when I was a registrar many years ago, and he was an exceptional clinician. And I remember the conversation very well with Julian about which path his career would take. So this is now back in the mid to late 1980s. And the big thrust of medical research then was cloning various genes that might affect human disease in one way or another. And I remember Julian saying to me, I don't want to clone just another gene. I want to make a contribution, you know, to patients in other and profound ways, and that got him down the path of training in philosophy and in ethics. So Julian's very distinguished. He has been a long-time editor of the Journal of Medical Ethics, which is the leading journal in the field of medical ethics worldwide. So that shows you the stature of Julian in his field. Second speaker is Professor Dominic Wilkinson, who's the Director of Medical Ethics and Professor of Medical Ethics at the Oxford Uhiro Centre. Like Julian, Dominic is also a clinician. He's a neonatal intensive care specialist, which I think brings a very interesting clinical perspective to the subject matter today. And Dominic works at the John Radcliffe Hospital at Oxford, you know, one of the premier clinical institutions worldwide. So what we're going to hear about today is autonomy, futility and assisted dying, and particularly the examination of the ethics of making decisions that potentially limit life-prolonging therapies. Very topical issue in healthcare, especially in Victoria, as we think about moving forward with the new assisted dying legislation. So I think very, very timely. We've got two absolute world experts, and really looking forward to the presentations. Julian, over to you.
Thanks, mate. Yeah, thanks, Grant. It's a great pleasure to be here. Grant invited me, and whatever Grant asked me to do, I do. As Grant mentioned, I was his resident when he was the oncology registrar, and he used to call me Lackey. I don't think he ever called me Julian. He just called me Lackey. You couldn't get away with that nowadays. But actually, I owe my place here to Grant, because it was actually when I was a second-year resident, I decided to do a Master of Bioethics part-time while I was working. And the lecture started at 5:15 at Monash. And in order to get out to Monash from the Alfred Hospital, I had to leave work early at 4:30, which was unheard of. And Grant said, look, I'll cover you for half an hour, which very rare for your registrar to cover you. So if you hadn't actually done that, I probably wouldn't have done the Masters and I probably wouldn't have gone on to do the PhD. So it's amazing how things work out. I want to today talk about I want to give you this quote. The most interesting and challenging issues in medicine are ethical, not scientific or technical. Now, who said that? Me. But don't forget it. I think actually I don't remember any of that stuff about wanting to make a difference to humanity. I just did this because I thought it was really interesting and really important, and actually more interesting than medicine. I just want to say a little bit about the sort of bigger picture of ethics. So whenever I come back to Australia, I get a speeding fine because the limits are constantly dropping, you know, from 80 to 60 to 40, and it's very difficult to pick up on what the kind of limit is where you're driving. So I've nearly lost my license on points. And it got me to think, what's the correct speed limit? Because in the UK, you can drive at 130, and in Germany, it's unlimited, and in Australia, it's 100. And there is no answer to that question, a single answer. It depends on how you weigh different values. Now, the safest speed limit is the lowest speed limit. The most economically efficient is a faster speed limit. So Holland recently increased its maximum speed limit to increase efficiency of transport. Germans like driving their cars, and the pleasure of driving speaks in favour of an increased speed limit. Carbon emissions, there'll be an optimum, probably a slower speed limit. And how you balance those will give you the right speed limit. But it's not as if 100 is right or 130 is right. And this tells you in a nutshell what ethics is about. It's about weighing reasons. And we can give different weight to different reasons. In medicine, if you like a very basic snapshot, there are two big values and then a third hidden one, which I'll talk about. The two big values are respecting people's autonomy and doing what's going to promote their well-being. And you can weigh those in different ways. It's also important to recognise that even though the speed limit might be 100, you can drive slower. You can choose how you drive within the limits of the law. And the same with assisted dying. We've now got legislation in Victoria that gives doctors the power to actively end patients' lives. But there are enormous opportunities to conscientiously object. It has basically the most generous provisions on escaping providing assistance in dying. But whether you choose to offer assistance in dying is an ethical issue, something that you as an individual or as a practitioner will have to make your own decision. And essentially the principles or ethics of assisted dying are the same as the principles I'm going to talk about today. It's about weighing reasons of autonomy against and reasons of promoting people's well-being or acting in their interests. I don't want to talk about cancer today because I couldn't find an interesting case, to be honest with you. But I want to talk about a case I've been obsessed with over the last 18 months or so, the case of Charlie Gard. How many of you haven't heard of this case of the baby last year who died, Charlie Gard? Just as a sort of straw poll, how many of you think that the doctors were right in not providing the experimental treatment? Can I have a show of hands? And how many of you thought the parents were right in what they wanted? Well, a lot of you are undecided. I think the parents were right. And my colleague Dominic, who I've got enormous respect for and is the world's best person in medical ethics, he thinks the doctors were right. And I want to talk about disagreement in medicine about these sorts of cases. But in fact, this case embodies the most important aspect of medical ethics, that is deciding what's in a patient's interests. And in particular, when could it be in somebody's interests to die? So we're seeing a big change in medicine. Last century, there were very few treatments. You diagnosed a streptococcal bacterial infection. There was only penicillin and you prescribed that and everyone was very happy because you went away and lived when previously you would have died. This was a paternalistic model of medicine. But today we have complex evidence with varying levels of confidence. Things aren't either proven or unproven. They're often got degrees of evidence and degrees of confidence. There are probabilities. There's different lengths of life from different treatments, different quality of life. People have different values. Some people want to live as long as possible. Some people want to live as well as possible. We've run up to the limit of what our finances can afford, and many cancer treatments can't be provided on Medicare. People are more powerful. They don't just trust what their doctor says. They're able to access information. We'll see in the case of Charlie Gard the influence of that. They're a massive technological advance. We're connected. And I think Charlie Gard, for me, represents the collision of 20th century medicine with 21st century medicine. And it isn't that things are black and white, it's that they're grey, and that we have to weigh competing reasons and values. And there can be reasonable disagreement, like the disagreement Dominic and I have over the case of Charlie Gard. And Dominic will finish at the end by talking about how we move forward, not in a time of consensus, but at a time of disagreement. So Charlie Gard had a disorder of the mitochondria. These are small power packs in the cell that provide energy. They were thought to be bacteria that the primitive cell sequestered. And these mitochondria have their own DNA. And in Charlie's case, the DNA wasn't being properly made. DNA is made up of 4 bases. In Charlie's case, his body didn't synthesize any of the 4 bases. There's a milder version where only 2 of the bases aren't formed, and that's called TK2, which affects mainly muscle. In Charlie's case, it affected every cell in his body, but particularly the brain and his muscles. That'll be important in a minute. So here's the timeline of the Charlie Gard case. He was born in August 2016 and he developed symptoms. So he was born normal. That's important to remember. He wasn't born profoundly disabled. So one of the issues with the case of Charlie Gard was there was a window of opportunity to trial experimental treatments. At some point that window closed, but when did the window close is the interesting issue. He developed symptoms of weakness very early and was transferred to Great Ormond Street, one of the best 4 children's hospitals in the world. And very quickly, a diagnosis was made by using next generation sequencing technology. So when this would have taken months or, perhaps they've never had a diagnosis, this was done very quickly within a month or so of him presenting. And the diagnosis was this RR2MB version of the mitochondrial disorder. But around this time, Charlie's mother discovered through searching on the internet that there was an experimental treatment that had been tried in the US on the milder version, the TK2 version, not on the more severe version that Charlie had, but on the milder version, with some quite striking success. One child apparently getting off a ventilator when the child had been previously dependent on the ventilator to help breathe. So Charlie's mother said, well, if it works for the milder version, why wouldn't this treatment work for the more severe version? And so she proposed this to the doctors who hadn't thought of it, and she was being treated by a mitochondrial expert. And they then got in contact with Michio Hirano, a world expert at Columbia University Medical Center, who was the leader of these trials. And he said, yes, replacing these missing bases would likely get through to the brain. And yes, it might have some effect, and he recommended a 3-month trial of treatment. So in December that year, a trial of treatment was being considered by the hospital. Treatment was very cheap, about £400 a month, and the only side effect was diarrhea if you got high doses. The doctors were considering a trial of treatment and brought this to an ethics committee. Why they brought it to an ethics committee, I'm not really clear. But while the ethics committee was waiting to hear the case, Charlie's condition deteriorated. He began to have fitting. Now, fitting is a sign that the brain is involved, which you would expect. It's a part of the natural history. And eventually he was put on anticonvulsants, and that was controlled. But around January, his fitting increased further, and for some reason, the doctors reversed their decision. We don't really know what caused them to reverse that decision. But they decided that his fitting was now so severe that he had such significant brain damage that a trial of treatment was no longer warranted. So they made a decision about what was in his interests. And they said it would be better to withdraw treatment and allow him to die. So that he wasn't going to recover, that the nucleoside replacement therapy, the experimental treatment, wasn't going to have an effect, and he should be allowed to die with dignity, die without further invasive mechanical ventilation and so on. But the mother said, no, I don't agree with that. I think he should have a trial of treatment. So then the case came to court, and between January and April was when, or around March and April was when the court heard the case, and that was really where the decision was made. And the Great Ormond Street brought a whole parade of doctors from the UK who all said that this wasn't in his interests, and Connie Yates, Charlie's mother, was able to harness Michio Hirano, but he didn't see the patient. He saw the test results, and he gave evidence to court, but in April, that Judge Francis, decided on the side of Great Ormond Street that further treatment would be futile and burdensome to Charlie, should be allowed to die with dignity. And then there was an appeal and a further appeal in the Supreme Court, the European Court of Human Rights, and finally, after the intervention of Donald Trump and the Pope, a re-examination of the case. But I want to focus on what happened in the first court case. So this is Charlie when he was born, and this is him at the end. Attracted worldwide worldwide media attention, and in fact, I think the public were right in this case. So people are often very critical of social media, and I think this was a case where it really forced people to re-examine what I think was old-style paternalism. The Pope became involved, Donald Trump, they were busy tweeting in support of Charlie, and it was that intervention that caused in July the case to be re-examined, and Michio Hirano, an Italian expert, came to the UK. They ordered a new series of tests, including a new MRI scan of the brain, which was still said not, on their view, not to preclude a trial of treatment. However, by that stage, his muscles had so degenerated that they both agreed that the window of opportunity was now closed, and they recommended withdrawal of treatment at that point. The mother accepted it, and Charlie Gard died. Many people think this is about parental rights, but it's not. It's about basic medical ethical principles. And I think that actually a broader view of ethics would have supported a trial of treatment in this case. Now, this is a very basic slide. In any potentially life-prolonging medical treatment, whether it's nucleoside replacement therapy, ventilation, antibiotics, feeding, anything that will keep you alive, there are three basic justifications for stopping it. The first one is the person themselves refuses, right? Competent people, Jehovah's Witnesses, can refuse blood transfusions. This didn't apply. Charlie wasn't refusing. His parents weren't refusing. The second one is that it might have some effect, but a very small effect relative to the amount it's going to cost to provide. That is distributive justice. Everything is limited. And in this case, I think this was the correct justification for not providing experimental treatment. This is what the doctors should have argued for, and they would have been right. But that wouldn't have stopped treatment with the parents' own resources. They went on to raise £1.3 million, nor would it have stopped them taking Charlie to the US, which the court did. The court actually prevented the parents taking the child to a world-class institution to be treated by the world's expert because they said it would be better for him to die. They opted for this third justification for withholding treatment, and that is it's not in the person's interests. That is, it's going to cause more harm than benefit. And this applies to many cancer treatments or any treatment that exists when there are marginal costs and benefits. Often the medical argument is made is that it's going to be against the person's interests, it's going to be harmful, or it's going to be futile. And I think that's a very difficult judgment to make. I'm going to try and show you just how difficult it was and how bad the reasoning was in the case of Charlie Gard. I think the much easier argument to make is that it might have a benefit, but we could bring about a much bigger benefit with the use of the resources elsewhere. But that leaves open for people to self-fund. We have a case in the Children's Hospital of spinal muscular atrophy, where exactly this scenario is playing out again. And you're going to face it more and more, where people say, oh, okay, you think that the treatment is too expensive, well, I'll fund it myself. Okay, and these three justifications mirror the three basic principles of medical ethics: respecting people's own decisions, their own autonomous decisions, promoting their well-being, and distributive justice. Now, in assisted dying, the first two are the main issues. There are two basic justifications for providing euthanasia or assisted suicide. One is that you're respecting the person's own wishes about how their life ends. The second one is that it's actually going to do more benefit for them than it's going to do harm because their suffering is so great. And the standard principle of medical ethics is that medicine should be provided in the best interest of the patient. That's, in one line, that's what medical ethics is: acting in the best interest of the patient. And the problem with assistance in dying is that the standard justification should be that assistance in dying is going to benefit the patient. But the puzzle is, how can death be better than life? Now, I think it can, but I think it's very difficult to make that decision. So in order to provide assistance in dying, you need a new justification that medicine hasn't traditionally embraced, that is, just respecting people's autonomy. But actually, I think that's where we find the most fruitful answers in assistance to dying. Okay, the real justification, or the best justification for denying Charlie Gard treatment or withholding potentially life-prolonging medical treatments is distributive justice in terms of quality-adjusted life years. So every country has a threshold of cost effectiveness measured in quality-adjusted life years. In Australia, it's about $40,000. In the NHS, it's somewhere between £20,000 to £30,000. Sorry, I seem to have lost my voice. Per quality-adjusted life year. Now, even on the most generous estimates, the cost per quality of nucleoside replacement therapy would have been over £100,000 per quality. So it's just not justified as a way of using public resources. But it didn't apply in Charlie Gard's case because the parents raised the funds themselves, and also they wanted to take him overseas. The justification that was used in Charlie Gard's case was the justification of futility. And this is a common medical justification. Doctors will tell you, oh, that treatment is futile. Now, there are some treatments that are futile, like trying to sew somebody's head back after decapitation. That would be futile. But it was nucleoside replacement therapy, in Charlie's case, futile. I want to show you just how value judgments have an inescapable and massively dominating place in medical ethics and how they can be questioned. So futility. There can be two ways in which some treatment, some experimental treatment, some new cancer treatment, nucleoside replacement therapy can be futile. First of all, it can just not be biologically active, right? So giving somebody, I don't know, calcium tablets for their mitochondrial disease, it's just not going to have any effect. There's no plausible biological basis for that. The second one is it could work, but the person is so damaged, so ill that their damage is so irreversible that they're not going to benefit, even though it could in somebody else have an effect. And both of these were used without dividing them in the case of Charlie Gard. So what about the first one, biological utility? The judge said it was futile. Now, the basis for this was this treatment had never been tried in a human being or an animal model with RR2MB. So in that sense, there was no direct evidence. But it had been tried in TK2, a related disorder of nucleoside metabolism, and on 18 patients and with significant effects. Now, does that mean that there's evidence supporting it? That's a value judgment. Hirano thought that there was evidence and there was a sound physiological basis for why replacing the nucleosides might also help in Charlie's case, but there was no direct evidence. Indeed, when it came to the re-examination of the case in July, Hirano produced evidence that it did have some effect in cultured cells with the mutation. And in fact, this justification for withholding treatment started to disappear, that it had no biological utility. Instead, the judge focused more on the second ground, that there was already irreversible brain damage and irreversible damage. Now, it's true that by July there was irreversible damage, but that was on the basis of a muscle scan, not on the basis of a brain scan. And in April, when the judge made the decision, the only evidence of irreversibility was an abnormal EEG. There was no evidence on the brain scan of structural damage, even though the judge made a mistake and claimed that there was. There was only an abnormal EEG. Now, I haven't found anyone who's been able to tie the pattern of EEG findings that Charlie Gard had to irreversibility. And in fact, there's some reason to believe that the EEGs that was present at that time didn't show irreversibility. And this is a case where Dominic and I have, through this case, we've shifted our views. And Dominic's view on this case, which he can articulate it better than I can, but one of the problems in this case was Hirano didn't see the patient in the first hearing. And my argument was it's irrelevant him seeing the patient. He could have seen all of the test results. Simply laying hands on the patient was irrelevant. But in fact, I'm inclined to agree with him now, because my understanding is that he didn't actually see the original EEG traces. He saw reports of them. And actually, if he'd seen the full range of results, his view might have been even stronger that the situation wasn't irreversible. But so we have one single finding in it, no brain biopsy, no structural damage on the MRI, just EEG findings. That, even at that stage, on the basis of the reports, Hirano said did not indicate irreversibility, and he would have been willing to treat. So Francis, the judge, made an error. He kept talking about structural brain damage, which there wasn't any, and this was appealed. But still, the Court of Appeal said it doesn't matter. He still had irreversible loss of neurons. He certainly had loss of neurons, but how many and how much recoverability was not something that was addressed. So everyone agreed that the probability of a successful outcome at this point was low. But Hirano said it wasn't zero. And he said if this patient was his, he would treat them. Now, the judge moved from a claim that it was near zero to it is zero. But near zero is not the same as zero. If I said to you, you're unconscious and you're certainly going to die, and there's a treatment that's got a 1 in 1,000 chance of curing you with no side effects, would you take it? It would be rational to take it if it had no side effects. 1 in 1,000 is greater than zero. Again, I'll come on to this point. So as I said, the judge moved from this claim about the smallness of the chance to it effectively being vanishingly small, or as close to zero as makes no difference, and so the treatment was futile. Now that's just a huge value judgment about A, the biological utility, and B, the level of reversibility. My reading of those facts and Hirano's reading of the facts were it's sufficiently great to warrant a trial of treatment. Great Ormond Street, Dominic's view of those facts is that it's not. But it's not clear that one of those is the right answer. And in those cases, we ought to defer either to the wishes of the patient or to the wishes of the parents in this case. This, I think, is a beautiful summary of the differences between the judge and Hirano. So Justice Francis says, Dr. I, this is Hirano, who has not had the opportunity of examining Charlie, who operates in what has been referred to as a slightly different culture in the United States where anything would be tried, offers the tiniest chance of some remotely possible improvement based on a condition which has been administered to patients with a different condition. I repeat, the nucleoside replacement has not even been tried on a mouse model. And Hirano, he cites, it's very difficult for me, never having seen him, being across the Atlantic and seeing bits of information. I appreciate how unwell he is. His EEG is very severe. I think he's in the terminal stage of his illness. I can appreciate your position. I would just like to offer what we can. It's unlikely to work, but the alternative is that he'll pass away. Now, that's exactly right. And the only reason not to give him a chance is because there'll be some downside to the treatment. So back in May, Dominic and I both wrote a pair of companion pieces taking different views of this before it became news. My analysis was that nucleoside replacement therapy wasn't futile. It was just very unlikely to work. And you wouldn't know until it was tried. The cost of providing him that trial of therapy was 3 months of intensive care. In my view, 3 months of intensive care was not a price too high to pay. The only evidence of irreversibility was the EEG, and it wasn't a flatline EEG. It simply showed evidence of fitting and what you would expect. So how low is too low a probability, too low a chance? Let me just ask you, imagine that there's a red pill or a blue pill. Don't scan that thing. This is a slide from Dominic. I can't get these things to work. The red pill involves you've got a disease and you're on a ventilator, and it involves withdrawal of treatment and you'll die painlessly and quickly. The blue pill means that you'll have 3 months of intensive care with tube changes, line changes, under sedation and analgesia, and a 1 in 1,000 chance of recovery, full recovery. Who would want the red pill? Show of hands. And who wants the blue pill? Well, when Dominic's done it somewhere else, this was the division of people, and people disagree because this is a value judgment about your evaluation of the risks and benefits. There isn't a right answer to that. And the beauty of autonomy is when it's unclear whether a risk is worth taking, you can ask the person. That's why in assistance in dying, provided that the person actually is suffering to some degree, does have a basis for their request, it's not completely irrational, we should give weight to their view. In this case, we should give weight to the views of the parents. Okay, so pain is another issue. The second feature of Charlie Gard's case is that the court tried to make a decision that his life was going to be not worth living. I think life can be not worth living, but I've never seen anyone, including any court, give a coherent, operationalisable, sufficiently detailed justification of what that would be to be used in a non-arbitrary, non-subjective way. Okay, so one of the claims in Charlie's case was that even if he survived, his life wouldn't be worth living. And the court appeals to these sorts of claims when it makes these decisions. It says the infinite variety of the human condition never ceases to surprise. And in fact, it defeats any attempt to be more precise in the definition of best interest. If that's the case, you ought to give weight to the individual's autonomy or the reasonable views of the parents. The only statement that Judge Francis made was that best interests encompasses medical, emotional, all other welfare interests. Well, how does that answer the question of whether his life would have been not worth living? He goes on to say the consensus was that his life shouldn't be one that was sustained. Now, what was that life going to be like? It was going to be severe cognitive impairment, likely immobility, tube-fed, dependent on a mechanical ventilator. Is that a life that's not worth living? Well, there are children who are paralysed on mechanical ventilation who we think it's in their interest to continue to live. The problem with appealing to disability is that no one is prepared to say what level of disability makes life a burden such that you'd be better off dead. Pain is one issue, but even in that case, it wasn't clear whether Charlie was in pain. So I don't have time to go through this. But on my view, any plausible account of a life worth living has to take into account 3 factors. One is the presence or absence of pain. The second is the degree to which an individual's own desires will be frustrated. And the third is lack of objective goods characteristic of a human existence. What are they? Well, one of them is a meaningful social life, being able to recognise your parents and friends or family, being able to substantively engage with them. It wasn't clear whether Charlie would have got to the point where, even though severely cognitively impaired, wouldn't have been able to enjoy that sort of very basic social existence. So I want to leave some time for Dominic. So Peter Singer and I wrote a piece arguing that neither in terms of evaluating the probability of a successful outcome or in terms of the quality of his life, that Charlie's life was against his own interests. Now, Peter has written a book called Should the Baby Live, where he defends infanticide. And I'm also a defender of euthanasia. But for neither of us was the case convincingly made, in this case, that this child's life and a trial of experimental treatment was not in his interests. So to finish, judgments about interests are very difficult to make. Very difficult to make. You need criteria like pain, like objectively bad levels of disability, like not being able to engage socially with those around you. It's much safer to appeal to distributive justice as a ground for limiting treatment, but then that raises the issue, should people be able to pay for their own treatment if they believe it's a value? What's different about the adult cases to Charlie's case is that autonomy can play an independent role. And with giving some weight to autonomy, we don't need to make complex judgments about whether this is or isn't in the individual's interest. So with assistance in dying, and indeed in treatment limitation in competent people, I think we should move away from the 20th century model of basing these decisions purely on best interests and giving greater weight to autonomy, but also considering the role of distributive justice in those decisions. But let me pass on to Dominic for his take on the case and the principles.
Thanks, Julian. So what I want to do, just in a little bit of time remaining, is a couple of things. So first, I'm going to paint a slightly different picture of this sort of case, because the nature of these cases is how you look at them. You can have a very different point of view. Sometimes these cases are a little bit like those rabbit-bird pictures. That depending on where you come from, what you're expecting to see, you see either the rabbit or the bird. And some people always see the rabbit or they always see the bird. So one of the things that I saw when I encountered this case was a situation that's not so different from the situation that I see regularly in intensive care. So I work in newborn intensive care. We look after very sick babies. Thankfully, most of those babies get to go home. Right? It's uncommon. Only sort of 4 or 5% of the babies admitted to newborn intensive care die. That's a much smaller proportion than adult intensive care, where 10 or 20% of patients die. But some patients do die, and we usually know in advance that these patients are not going to survive. And sometimes we know in advance for a long time that they're not going to survive. And pretty much every time I go and work in the intensive care unit, there's at least one, sometimes more than one baby, who, when we go around and review the babies on the ward round, I know in my heart of hearts, or at least I strongly believe, that baby is not going to make it home. And in almost all cases, there often have been multiple conversations with the family about what the future is likely to be for that baby, and often significant disagreements about what the right thing to do is, for all the reasons that Julian has pointed out. And so because we do give enormous weight to parents' wishes in intensive care, we continue treatment, and we continue that treatment for weeks and sometimes months. And in that time, as a doctor in intensive care, I observe those children having all sorts of unpleasant procedures that, despite our best efforts to provide pain relief, are clearly causing the child discomfort, pain, suffering. So that's the perspective with which I came to this case, knowing that we have these children in intensive care, that sometimes it's very clear that we're doing more harm than good. So in Charlie's case, the picture that the professionals saw was a child who had progressively deteriorated. He had a severe mitochondrial disorder. They started out not knowing what the exact cause was. It then became clear that he had a genetic diagnosis of this exceptionally rare condition in which all previous children had deteriorated and died, that these children became paralyzed, completely unable to move, therefore dependent on a ventilator because they can't use their breathing muscles, but also developing progressive deterioration of their brain. As in Charlie's case, starting out initially just completely paralyzed, but neurologically normal, but then starting to develop progressive seizures. And that was what the clinicians saw. So within that picture, the doctors approached the family and said that we don't think it's the right thing to do to continue to keep Charlie alive. can't see that he can survive. We think it's the wrong thing to do to keep him alive in a setting where death is inevitable, and all we can do is to cause him the harms of our treatment. The family had then found this possible treatment, which had never been tried in Charlie's specific form before, and the hospital had started to engage in a process of assessing whether or not this treatment should be provided. They'd been in contact with a specialist in the States who said, well, I think it's unlikely to work in this more severe variant, but it could, as long as he doesn't have irreversible brain damage. The clinical team then felt, given his subsequent deterioration, his development of seizures, that he had developed irreversible brain damage. And at that point, the family specialists in the US and the specialists in the UK divided. So that's the kind of perspective with which I started to look at this case. But one of the things, kind of stepping back, that it points to is one of the challenges we face, particularly in this era, that when we're thinking about these very difficult ethical questions, particularly in the setting of emerging treatments, conditions that are exceptionally rare, and particularly when we're talking about, but not exclusively when we're talking about children, that there can be a range of different perspectives. So one of the challenges for ethics and for all of us as patients is, how do we manage a situation where there are different views? So there are two different types of disagreement that we encounter that are common. One of there was a survey recently of health professionals in Canada working in pediatric and neonatal intensive care, asking them how many of them had encountered significant conflicts in the setting of end-of-life decisions, and a large proportion of them over recent times had encountered such conflicts. Interestingly, 2/3 of those conflicts were conflicts between health professionals about what the right thing to do was for the patients. And then in 1/3 of those cases, those conflicts were between the family and the health professionals. Well, what should we do in the setting of disagreement? Well, as Julian pointed out, when we think about these cases, there is something different about the children cases from the adult cases. So when we're thinking about adults, thinking about yourselves or your family members, we're trying to weigh up these decisions about, well, what's best for the patient. We have the resource of asking the patient, if they're still able to talk to us, well, what do you want? What do you consider to be best for yourself? In the case of Charlie Gard, if Charlie had been an adult and been able to express that he, for example, was dead set on pursuing this experimental treatment, even if he lost consciousness and were connected to a ventilator, even if it were extremely unlikely to work, his wishes in that setting would have been extremely important in terms of thinking about, well, what would be best for Charlie. When we think about young children, we don't have that access to what the individual themselves would choose. So we have this much more difficult attempt to work out, for somebody who's never been able to express their wishes, what would be best for them. So there's disagreements between the family and the professionals. There's disagreement between the professionals. And one of the things that Julian and I started to think about when we were thinking about this case, and in the book that we had forthcoming later this year, is, well, here's a situation where we disagree as relative experts, as both as health professionals and ethicists. We have this wider situation of patients and doctors disagreeing, different doctors disagreeing. Well, how do we deal with those situations? We're not always going to be able to agree on these cases. It's unrealistic to imagine, given the kind of fundamental values that are involved, that we're all going to agree. So what should we do? Well, one of the things that Julian has pointed out is that where it comes to a situation of competent patients declining treatment, refusing treatments, that we normally think that people have an absolute right to refuse treatment. So thinking in terms of autonomy, that was one of the parts of the title of the talk. Autonomy is at its strongest understood as a negative right. So people have an absolute right to refuse any form of medical treatment as long as they have the capacity to understand what's at stake. That includes if the treatment would certainly be beneficial. So you could refuse antibiotics or treatment for a completely treatable infection, skin infection, pneumonia, even if you would certainly recover with that treatment. If you have capacity, you can refuse that treatment. If you're making a request for a treatment, that then is different in two ways. One is that it involves the health professional in providing that treatment. The other, very importantly, is that treatment is potentially then not going to be available for others. And one of the challenges for all of us who work in public health systems is that health professionals, much as they are absolutely committed to the patient in front of them, are also always having to think about their capacity to treat other patients. So within the public health care system, there's a need as a society collectively to try and set some limits around that. So one of the things that we set out in the book is to try and think about a process for thinking about resource limits in the context of these disagreements and when that should apply. That clearly doesn't apply where somebody is self-funding treatment, or at least on the surface of it. But one of the things that became apparent to us when we discussed Charlie's case with health professionals in the US is that limited resources like intensive care beds, even where they're self-funded, that there are finite limits to those. So if Charlie had gone to the US, occupied an intensive care bed, even being paid by the crowdsourced funding, that would potentially have made that intensive care bed unavailable for other patients who could potentially need it. So one of the challenges is, in the face of disagreement, is about how we work out where there is what we call reasonable disagreement. So there is disagreement that we can all have about different treatments, but where there's reasonable disagreement, where individuals have views that can be understood in terms of values, principles that can be articulated and respected, and where that treatment is not going to harm others by depriving them of treatment, the general principle is that health professionals should respect that. So I'm going to wind up there. We do have a capacity, we do have a bit of time to open up for questions. Thank you very much.
Thanks very much, Dominic. The Charlie Gard case has been a case of huge interest around the world, so I think it brought out the principles here really clearly. So we've got 10 minutes for some questions, and I'd like to open up to the floor for questions. Well, I might kick off with the first one, gentlemen. So Charlie...
You've got to go in front of the camera.
Oh, thank you. Never like being in front of a camera. Yeah. So the Charlie Gard case is, of course, of a neonate who really you can't ask his opinion as to what he would like in an autonomous way. So how do you assess autonomy? Is there age or other parameters that make sense, from an ethical perspective about assessing autonomy? This is relevant, I think, in our current assisted dying situation in Victoria, because you can't lay out your intent years before in Victoria. If you then lose autonomy, you have to be autonomous at the time with assisted dying, with the legislation in Victoria where the decision is made.
Yeah, so one of the big questions here is, what is autonomy and what counts as an autonomous decision? And so a minimal one would be just a decision made by a competent person who's got all the relevant facts, who knows what the alternatives are and the consequence, and who is acting freely. So that's the low threshold. So on that view, you know, under the current Victorian legislation, provided if you've got 6 months to live, is that
yeah, depending on the diagnosis, yeah.
6 months to live, say, and you're competent, and you know the facts and the alternatives, including the availability of palliative care, etc., and you're not acting under the influence of family or other people coercing you, then it's an autonomous decision. Now, I think that's too minimal. I think autonomy has to do not just with desires, but values that are important in your life, that have shaped how you live your life. And so I think that's, so I think that just because somebody desires to refuse treatment or to die through assistance in dying doesn't mean that respect for autonomy means you ought to immediately assist them, or it requires some kind of evaluation of the quality of that desire. Now, that's a controversial claim. Many people would just say, as long as they're competent, that means, you know, able to understand the gravity of the decision, able to understand what's at stake, able to understand the information. That's enough. But, you know, there are different, in philosophy, different accounts of autonomy. And as a professional, if you're deciding whether to withdraw treatment or to provide assistance in dying, you have to decide, what do I think autonomy really consists in? And is this a desire I think there's a good reason to satisfy? I had a case here of Michael Bales, but there was also this case in Australia, I think Peter Singh was telling me yesterday, about the 104-year-old professor from the Murdoch Institute who went to Dignitas. Oh, you know, that's a case where you have to say, has that person got a good reason to ask for assistance in dying? And as a professional, given the way the legislation, you can decide to say no, or you can decide to say yes, if they have 3 months to live. So, you know, I think it's all there to play for. And the most difficult and interesting decisions are still there to be made about whether you think the suffering is so great that their life isn't worth living, whether you think the desire is really autonomous or not. Did you want to say something about that?
Yeah, I mean, so one of the things about it that's highly relevant in relation to children is that clearly children develop autonomy. And when we think about the development of the capacity to make decisions in children, it's not all or nothing. It's not as if a child suddenly at a magical age of whether you think that's 16 or 18 or older suddenly becomes able to make decisions. Is that they develop a capacity for reflecting on those decisions over time. So capacity is a matter of degree, and there's going to be at least some degree of arbitrariness in where we draw the line in assessing somebody's capacity as having enough capacity to make a decision. When we're thinking about decisions in relation to capacity, whether patients have capacity to make decisions about medical treatment in older patients, again, there may be a spectrum of loss of capacity in somebody who's got progressive cognitive decline. One of the things that we might reflect on is that what you need to make any individual decision is going to change. So some decisions you need to know much more complex information, and some decisions are much more serious. So we may apply a higher threshold for thinking that somebody has enough capacity to make this decision. So we might tend to think that somebody needs to have a higher level of capacity to make a decision about assisted dying, for example, than consent for cataract surgery, for example. And typically, when patients are consenting to a medical procedure that a medical professional thinks is in their best interest, there's a very minimal assessment of the patient's capacity. As long as they're signing on the dotted line, there isn't a huge kind of interrogation of whether they really understand the ins and outs of the procedure. If they're making a counterintuitive decision, a decision that seems to be contrary to what the professional thinks is in their best interest, then the professional will get all sorts of potentially very agitated about assessing, do they really have capacity to refuse this treatment or to consent to this slightly unusual treatment.
Okay, now a question from the floor, please.
Yeah, I just wanted to say what I found really, really most tragic about that case with Charlie Bard is the fact that his parents were obviously just totally devastated by this and were trying everything to keep this child alive, because in society we don't really understand how are we going to go on without this person in our lives, be it husband, wife, child, whatever. And that whilst he was still alive, all this stuff was going on and detracting their attention from their still live child. Do you know what I'm saying? So, I mean, I don't know the degree to which that happened, but
I mean, I disagree. I got to know Connie Yates, the mother, over the case and since then. And even during the case, she seemed to be very focused on trying to do the best for her child, and she wasn't under any illusions about him surviving or about this is going to cure him. And actually afterwards, one of the most kind of poignant things, which I thought, you know, there's been a lot of criticism of her, and I don't know her very well, but everything that I've seen has extremely impressed me. And the thing that really impressed me was afterwards we were talking with her, and one of the decisions they made early on was not to put a tracheostomy in. And there was a lot, and she was fighting for a tracheostomy to be put in, and it was never put in. And she said, if they just put a tracheostomy in, we could have taken him to the park and had some time with him. And she wasn't, and this is after, and she's kind of moved on now, and she's doing constructive things like trying to introduce a law to prevent this sort of case, and you know, is thinking about writing a book. I mean, I think she seemed to me to be a mother who was doing the best for her child, and was entirely appropriate. I mean, I don't, you know, I don't know what else she should have done, really. All right.
It wasn't that. It was more that I just think in this whole business, sometimes the fact that this child is still alive, and I feel sad for her if she was distracted from enjoying that child while he was still alive. And I'm not saying that she was. I'm trying to broaden it out to just generally.
I mean, so one of the things about these types of disagreements between family members and a seriously ill, whether it's a child or an older patient, is that sometimes the health professionals do get a sense that actually the focus has moved from what is best for the patient to sometimes what's best for the family members. So it can be very difficult for family members to separate in their own minds what their own distress at losing a family member and what would be best for them, which is often that their loved one continues to live, from the question about what would be best for the patient themselves and what the patient would genuinely have wanted. So not necessarily in this case, but in quite a lot of cases, there is this sense amongst the health professionals that what the family are articulating is they are desperate for themselves for this patient to survive because they cannot face the loss that they see ahead. And that is what's motivating them, not necessarily a kind of independent assessment of, from the patient's perspective, what they would want or what would be best for them. The other thing that you articulate is the way in which these disputes can get a life of their own, and sometimes in which external voices, particularly in the light of social media, might play into these disputes. And certainly in some of these cases that do reach the kind of heights of media attention, there can be some very unhelpful interventions from outside individuals that can make it even harder for those families to try and see through and to work out what would be best.
I think just what I will say one thing that Dominic didn't say at the end. One of his like genius ideas was, and this is what we found by disagreeing and arguing about this case, a whole bunch of blogs and articles and so on, is that in medicine people think there's got to be consensus. You know, these team meetings that get everyone to agree. And what we discovered is actually you don't necessarily want consensus, and it's not necessarily a healthy thing. Dissensus can be a very valuable thing. That is reasonable disagreement. And Dominic's view now, I think, and my view is, as long as there's one reasonable person supporting either the patient or even if a large number of medical professionals disagree and there's consensus that as long as there's one reasonable clinician wanting to provide this treatment, then we ought to err on the side of dissensus. So in my view, Hirano was a reasonable clinician offering an alternative. Now, I think Dominic's view before was because he hadn't seen the patient, he didn't count as reasonable dissensus. So we had this disagreement about whether there was dissensus in the Guard case, but we do have an agreement about the importance of dissensus. Is that correct?
Yeah, that's right. So one of the things for, again, to kind of take it out of the child context, think about adults, is if you as a patient are trying to find out which course of action to follow, or as a family member, which course of action, and you have some people who are articulating, expressing a view, what you need to do is not just assess whether they're expressing a view that you like, but also the basis for the view that they're expressing. So is it reasonable? Do they know all the facts? Have they, for example, examined the patient, looked at all the medical records? Do they have the relevant medical qualifications, if it's a medical treatment, to be able to assess it? And on what basis are they making those recommendations? So in the case of Charlie Guard, here it looked like there was a highly qualified medical expert, but potentially lacking some of the information that the clinicians in London who were caring for Charlie had access to. So one of the reasons for the court not giving weight to his views, not regarding this, was that the court said that he didn't have the right sort of information to be able to express a genuine view about what would be best for Charlie. So if he had come and examined him, the court might have reached a different conclusion.
Okay, final question from Dale Fisher.
Thanks, Grant. That's not a question, it's a comment. I'm Dale Fisher, CEO of Peter Mac. There was a slight implication, or I understood, with the Voluntary Assisted Dying Act that it's physician, initiated, or I just wanted no one to leave this room without knowing that it is a patient-requested assistance request, and it is self-administered. It is not physician-administered or requested. So I just wanted to clear that up. And there'll be a session tomorrow, actually.
Yeah, I think this is unique in the world.
Yes.
The doctors can't even raise the possibility,
yes.
Which you're completely. I didn't mean to imply that.
No, but I felt that. I just.
No. It's absolutely striking that a doctor can't even tell a person of the kind of availability of something in society, but that is the law. So it's a very, very constricted law that you've got here.
And look, I think that's a great point to finish on, the importance of autonomy in healthcare, decision making that we do hold as a very high ethical standard. In fact, in cancer multidisciplinary care, we not infrequently get a disagreement around the multidisciplinary care table as to the best treatment option for the patient. The response, patient autonomy rules, and so the options are put to the patient for discussion as autonomy is so.
I mean, my impression is, I hope this isn't still on, but I think Australia is a long way ahead of a lot of other places in the world in terms of the involvement of the patients and the parents in these sorts of decisions. So well done, VCCC.
Okay, well, thanks. Just reminds me to thank our speakers. You'll see up on the slide here the next 4 Monday lunch lives, some really interesting discussion, including financial toxicity, which was something I was going to raise with you at distributive justice. Now, what you've noticed from when I flick through all the slides is that we have to get Julian and Dominic back for another session. I see lots of nods around the room. Yeah. Okay, so I'd just like to give you each a small gift from the VCCC. Thank you very much for your attendance, and we look forward to everybody's participation next week in the Monday Lunch Live. Thank you very much.
Thanks very much.